Hello and welcome to this lecture. Today we are going to discuss acute respiratory distress syndrome, and I'm going to start with the presentation of one case. We're talking about uh, a 60 years old man presented to the emergency department complaining of persistent right-sided chest pain and cough. The chest pain was pleuritic in nature, so that's the most important thing when we read the case, and had presented for last month. The associated cough was productive of yellow sputum without hemoptysis. This is another important point that it is productive yellow sputum but without hemoptysis. He had unintentionally lost approximately 30 pounds over the last 6 months and had nights sweaty. The patient smoked one pack of cigarette daily for the past 50 years and denied recreational drug use. He reported ingesting 12 beers daily. Again, this is very important when we talk about the use of cigarettes and for the past 50 years. So he is a chronic smoker. Then he ingested 12 beers daily. So that's another important point. And had delirium tremors, remote right-sided rib fracture and a wrist fracture as a result of alcohol consumption. He was initially admitted to the general medical floor for the treatment of community-acquired pneumonia and for the prevention of delirium. By hospital day 5, his respiratory status continues to worsen, requiring transfer to intensive care unit for hypoxemia, respiratory failure. His neurological status has also significantly deteriorated with worsening confusion, memory loss, drowsiness, visual hallucinations, and patients start seeing the worms. So, what are the learning objectives for this topic? We need to see that causes of acute respiratory distress syndrome, understand the morphological characteristics and clinical presentation, and how can we differentiate between direct injury and indirect injury. And the last, we need to discuss the pathogenesis of the disease. So, acute respiratory distress syndrome is a respiratory failure that occurs within 1 week. Usually, it occurs a sudden failure, and it is graded based upon the severity of the changes in the arterial blood oxygenation. So, the key characteristics in acute respiratory distress syndrome is the changes in the arterial blood oxygenation. Why this has occurred? Because maybe it come of direct injury, or it sometime you can say there are indirect injury, or any insult that's on the respiratory system, or any injury, sudden injury that leads to change in arterial blood oxygenation. What are the cause of the injuries? On figure A, we mentioned that it could be direct injury or indirect injury. Indirect injury is as a result of sepsis, whereas direct injury, such as pneumonia, is an example. Whereas the inflammation occur, and that inflammation activate the immunity, and then tissue injury or dysfunction occur, and then it leads to inflammation. So we will discuss in detail the injuries later on. So what happened after the injury caused because of sepsis or pneumonia? It can affect the alveoli, especially bilateral injury to alveoli. And this is on the right side is showing you the normal and injured alveolus, where you can see on the right side we having injured alveolus containing activated macrophages. That's one of the key characteristics. Then the presence of the hyaline membrane, then the alveolar edema, then the presence of the myofibroblast, and then interstitial edema, and then at the end damaged endothelium cells, and maybe the formation of microthrombus formation and neutrophil activation. So you can see that what are the key characteristics. The key characteristic is the formation of the edema, especially alveolar edema. Then activation of the inflammatory mediators such as activated macrophages, neutrophils, and then we are also showing you the presence of the formation of microthrombus formation or the interstitial edema. So you can see that the edema, inflammation, and inflammatory mediators are easily expressed in that picture. What are the what causes severe ARDS, which is acute respiratory distress syndrome? In severe cases, what happened? You can see that respiratory insufficiency was found. Then there will be cyanosis, which is known as the bluish of the peripheries on your hand and toes, and severe arterial hypoxemia because change of the arterial oxygenation. As I mentioned before, that changes in arterial blood oxygenation is the key characteristic, and that is why we mentioned here that severe arterial hypoxemia will be occur. So when we discuss about histopathological manifestation, it is, we can explain in terms of diffuse alveolar damage. So in generally, it is actually disturbing or damaging the alveoli. And morphologically, how the lungs look like. The lung look like dark red, firm, airless, and heavy. And the microscopic examination reveals the following things. Number one, capillary congestion, necrosis of the alveolar epithelial cells, interstitial and intra-alveolar edema, as we have seen in my previous slide, hemorrhage, collection of neutrophils, hyaline membrane, fibrin-rich edema, and necrotic epithelial cells. So that we already discussed that in this picture. If you take a look at, we found macrophages, neutrophils, alveolar edema, and interstitial edema, and the presence of the capillary microthrombus formation, and the presence of the hyaline membrane, that green structure, or we can say that, if I need to explain to you, the wall is surrounding by the hyaline membrane. So that is one of the key characteristics in this disease. Okay, this is the pictures of some histopathology. First of all, we need to see that how can I explain them. Before try to understand the histopathology, you need to see the normal structure. This is a normal physiology of the respiratory lung, where you can see that it consists of terminal bronchioles, respiratory bronchioles. On the distal end, we have alveolar sacs that are connected with the ducts, alveolar ducts, and a round balloon type structure is showing you the presence of alveoli. And this is the physiological picture. This picture on the right side, which you can see, this is the histology of the normal bronchioles and alveoli. How can you understand this thing? If I draw this picture like this, and then you can able to understand this histology. And after, when you get to understand the histology, then I can explain you histopathology. Now I am drawing it. If you observe this structure, you can see this. Now if you take a look of this one, this structure is showing you the presence of alveolar ducts. These all structures is showing you the presence of alveoli. These are known as respiratory bronchioles. So you have to understand that the normal histology, that this structure is respiratory bronchioles. Inside we have alveolar ducts, and then we have alveolar sacs, can be seen very easily. So this is how it look like under normal circumstances. So when we take a look of the gross structures, first we take a look of gross structure. This one, we already discussed that the lungs will be appear like the red color. Okay, it look very heavy, and it look very congested and heavy. Why? Because obviously the presence of the hyaline membrane and the presence of the this hyaline membrane make the lung heavier. That is one of the key characteristics. So we mentioned dark red color, firm, airless, and heavy. So these two characteristics of firmness and heavy is because of the deposition of the hyaline membrane. As we see in this case, I mentioned this. So this layer of hyaline membrane make it additional weight to the lungs. Then it must be appear dark red in color, and then it will be airless because of the capillary congestion, as microscopic characteristics reveal the presence of the congestion. So that is why it look like that. If you take a look of microscopic characteristics, this is a picture of small, you can say that alveoli. And if you take a look of these two, this character that I'm going to highlight with another color, let me draw this. This is actually showing you the presence of the hyaline membrane. So that light pink color is actually showing you the deposition of the hyaline membrane that can be seen very clearly, and that actually makes the lung heavy, and the congestion also occur. That is also very important. So I mentioned here that the main thing is that some alveoli will be collapsed, some alveoli will be disindented, their structure is disorganized. The hyaline membrane and thickening of the alveolar septa is key observation in all of these pictures. So that's the key thing we have to see. On the right side, this is a picture to compare from, this is a normal histological structure. And you can see this is respiratory bronchiole, this is alveolar ducts. RB stand for respiratory bronchiole and AD stand for alveolar ducts. But when you compare, this is a normal picture, and then compare with these pictures, that picture A and picture B. So what is the key difference you found? The key difference you found that you cannot found any congestion here. Respiratory bronchioles and alveolar ducts are very clear. There is no hyaline membrane. The air passage is clear. No congestion. You can see that the layers and the septas are very normal. They are thin. But when you take a look on these structures, these all and these structures, they are presence of the congestion and hyaline membrane. That actually showing you that what happened in terms of this disease. So this is one of the clear demarcation that can be found. This is a normal picture that I have explained. So let's discuss the clinical features between direct lung injury and indirect lung injury. The common causes of direct lung injury is pneumonia, and it leads to the aspiration of the gastric content, whereas indirect lung injuries occur because of the sepsis or shock. Even sometimes the people that drink alcohol a lot, they also get prone to sepsis. That is why if you take a look of our presentation, we mentioned one thing, that patient is alcoholic, he drink alcoholic. So if a person is dependent on alcohol a lot, then what happened that he may prone to more infection. So sepsis can be occur more commonly to the patient that are more alcoholic. So you need to observe, you need to take the case history of the patient, that patient is either alcoholic or smoker or not. Then the uncommon causes we mentioned, both are different. In direct injury, it could be because of the pulmonary contusion, fat embolism, or because near to drown, or inhalation injuries, because we already know that this is acute respiratory distress syndrome occur because of the sudden effect. So it is more like an accidental injuries in terms of the direct lung injury, whereas inhalation injury could be occur, maybe a patient inhale carbon monoxide, CO, which is carbon monoxide gas, and it can cause the lung injury. Whereas indirect lung injuries could be because of the chronic diseases such as cardiopulmonary bypasses, sometimes acute pancreatitis, or sometimes the drug overdose, or transfusion of the blood products such as platelets can lead to the indirect lung injury, because it is also a sudden change but not direct effect, but indirectly affecting the lungs. So we need to monitor the patient lungs when giving the cardiovascular bypass or treatment for some medical disorders, some blood disorders, or the last we will discuss uremia as well. What is the pathogenesis of that disease? The pathogenesis of disease, I already discussed before in small, but I have to need to explain that how pathogenesis occur. So in this case, in acute respiratory distress syndrome, the main thing is that the integrity of alveolar capillary membrane has been compromised by endothelial and epithelial injury. So the first thing is that there will be endothelial injury or there will be epithelial injury, and then the formation of the inflammatory reaction occur, which I already discussed, that formation of the neutrophils or macrophages will be seen as early as 30 minutes after acute insult. There will be increase of the intraleukotriene 8. So the key characteristic that will be found is the formation of intraleukotriene. There you can see these leukotrienes, and the main thing is that these formation of the intraleukotrienes are the key characteristics in the pathogenesis of the disease. And then after then we see that a potent neutrophil chemotactic and activation agent will be occur by pulmonary macrophages. So you can see that after the formation of the leukotrienes or intraleukotrienes, the chemotaxis occur, and then you can see that it travel to the endothelial cells, and then you can see that it injured and swollen the endothelial cells. So the intraleukotriene formation followed by the chemotaxis leads to the injury of the endothelial cells. And then what happened that if it goes inside, it is responsible for neutrophil sequence or the formation of the nucleophils, in simple words. Then the release of intraleukotriene 8 and other factors such as intraleukotriene 1 and tumor necrosis factors are responsible for the activation of the endothelial and then activation of the neutrophils, as I discussed before. And neutrophils have played the most important part in the pathogenesis of this disease. And a histological examination of the disease show the presence of a number of neutrophils in the vascular space, in the interstitium and in the alveoli. That is the key characteristic for the diagnostic purpose, and it can cause damage to the epithelium and endothelium cell, which is appeared in the form of the vascular leakage and the loss of the surfactant. That what is the function of surfactant? Surfactant provide the support to the lung. So that sport has been finished because of the leakage, and that explains in terms of pathogenesis of the disease. So thank you so much for today's lecture. Hope to see you again.